Hi, I'm Matthew Weinstock, Senior Editor for Hospitals and Health Networks, reporting to you from San Francisco, site of the 20th Annual Health Forum American Hospital Association Leadership Summit. The theme of this week's meeting has really been getting from the first curve to the second curve, creating the value proposition. A key part of that is going to be how hospitals implement health information technology. I'm joined by Dr. Farzad Mostashari, head of the Office of National Coordinator, to discuss some of the trends he's seeing in health IT implementation. Dr. Mostashari, thanks for joining me. So we know that the Stage 2 rule has been delivered to the Office of Management and Budget, and while it's technically a CMS regulation, you've had some input into that. Can you give us any insight as to what may be in that regulation?
Well, I think it will come as probably little surprise that we will be pushing on standards-based exchange and on patient engagement aspects, in addition to continuing really what was in Stage 1, because it does take time to make the most meaningful use out of the meaningful use measure. So I think there will be, few surprises, and it'll be seen as more of a continuation and a balancing.
There was some concern from the provider community that perhaps Stage 2 was a bit too aggressive and set the bar too high. Were those concerns, A, valid in your mind, and B, were those addressed in the regulation?
We do listen carefully, and we've been at this for a while now, and we have to really balance the needs of the situation and against how fast the industry and providers can adapt and change.
Let's shift a little bit to off of the proposed regulations and look at the industry as a whole. What is your sense of where we are in terms of health IT adoption?
Well, the adoption numbers are really pretty impressive. We've seen a doubling of adoption among office-based practices, among hospitals, really pretty dramatic shift. And from all leading indicators, those trends continue. We just heard from a more detailed analysis of the National Center for Health Statistics on office-based practice, that half of those who don't have an EHR yet have either purchased it or are planning on purchasing it in the near future. That the largest single group of providers in terms of their adoption year was just in the last year available. So by all accounts, adoption is accelerating and continuing. I think if we're not already at a tipping point, we will be soon.
That's the theme of the meeting here, right, is to get from that first curve to the second curve. Have you seen IT do that broadly, or are we still having pockets where it's happening and pockets where they're lagging behind?
Well, I'll say nobody who's on the second curve, who has really transformed care delivery, has done it without IT. Right? You need information to be able to do population health management. You can serve an individual quite well. You can deliver excellent customer service if you wait for someone to walk in the door and then you go and pull their chart, or you make a new chart for them. What you can't do with paper charts is ask the question, who didn't walk in the door? Who's gonna walk in the door? So how do we effectively use data as an asset, as a foundation, and the information tools to be able to look at the entire denominator? That, I think, is where information technology is going to be critical.
But how do we get hospitals off of thinking of meaningful use and thinking of becoming meaningful users? So there are those that are looking at the incentive payment at the end as maybe their incentive, as opposed to what you're talking about of getting to that point of a value-driven IT system.
Well, I think it's meetings like this that help leaders in the hospitals look beyond the payment as an incentive and look towards the future of what is their healthcare system going to have to be able to do? What are the new capabilities? What are the new workflows? What are the new ways of engaging with patients? If you're an accountable care organization, as one ACO said to me, we can't do utilization management anymore because the patients are free to go wherever they choose. We have to be sticky, right? Sticky, that's great. The hospital's thinking about how to be sticky. And And those are some of the new capabilities that are absolutely supported by what's in meaningful use if you use it that way.
So you said we're at the tipping point on the adoption curve. Where would you say we are on health information exchange?
My hope is that we're approaching a tipping point on information exchange. One of the things that's been actually exciting to see is now that there is a business case for information exchange, the verb. There's a business case for hospitals and care networks to exchange information and to coordinate care. Now that there is a business case for that, there are a variety of different models that are popping up all over. It's really actually a big growth area in terms of people purchasing and looking for different solutions that meet their needs, that meet their business needs, that meet their use case, that meet their level of trust, that meet their financial arrangements. And there's a whole host of different approaches out there: vendor-supplied solutions, local RIOs, state exchanges, national networks, direct peer-to-peer communication, and it's all good. And that's why I think our emphasis should be on information exchange, the verb. Our goal is to have health information follow the patient where they go. How you do it, as long as we can reduce the costs of doing that by common standards, common building blocks, it's all good.
And you're optimistic that we do have finally a sustainable business model for information exchange?
I think we do for particular scenarios. People want to reduce readmissions, right? What hospital is not thinking about how to reduce readmissions? So flows of information from the discharge to the long-term care facility to the primary care provider, there's a clear use case for that all over America. People want to be able to manage patients when they're being referred or transferred between settings. There's a clear use case for that. People want their lab data. They want to be able to push information to the patient. When someone hits the emergency room, they want to notify their primary care doctor. Those are all use cases for which now there is a business case. And we need to build on where there are existing business cases.
I want to change gears a little bit now and talk a little bit about the IT workforce. We know that there are some shortages out there, as there are across healthcare.
Jobs, actually.
Jobs. So how does ONC monitor what's going on within the IT workforce? And do you have concerns that between the vendor side and the provider side that there aren't enough people to fill those roles?
We're quite concerned, and we actually have been monitoring some like the online jobs postings that have tripled since the passage of high-tech. Vacancies that are being posted in both the hospital side and on the IT side. The Bureau of Labor Statistics reported that there were at least 50,000 IT jobs added in healthcare in the past 2 years. And helping to connect people who are looking for jobs, right? And this increased demand in the job market is a real important priority. So I think one of the key challenges is work experience. So how do you take someone who maybe worked in the financial sector and in IT for 15 years, they're a mature professional, but they don't have healthcare experience. Many healthcare institutions aren't going to hire someone unless they have experience in healthcare, but it's a catch-22. So how do we get apprenticeship opportunities, internship opportunities? And I think that's something that hospital human resources should look carefully at, offering those kinds of opportunities to the graduates of our community college programs.
Well, I appreciate you taking some time this morning to be with us.